All right, so this is where we were before we ended the first session. And what we were going to talk about was clinical correlates of transpulmonary pressure. So this is actually, the more clinically relevant part of the discussion. So before I do that, I wanted to add a recap slide because we talked a lot this morning about different pressures and there's a lot of terminology. So again, going back to the single compartment model, we have to stick to this, and it's going to help us a lot. So we have the single compartment of one airway as the resistive part of the circuit, and we have these elastic components here, which are the alveolus, which represents the lung parenchyma surrounded by a chest wall. So that's the single compartment model. We have the four pressures, at the particular locations, which are already listed here. So the airway pressure at the top, the alveolar pressure right here, the pleural pressure in the pleural space, and the body surface pressure, which is atmospheric pressure, which is typically 0. And so then we define the various pressures across specific locations. So we defined 4 of those, and the 3 of them were contiguous. The first one was trans-airway pressure, which was the difference between airway pressure and alveolar pressure. The second one was trans-alveolar pressure, pressure across the alveolus. Again, the trans-airway pressure is a resistive drop in pressure and only exists during airflow. The trans-alveolar pressure is the really important one. This is where the money is. This defines alveolar inflation and is pertinent when we talk about ventilator-induced lung injury. So this is the more, in other words, this kind of describes alveolar stress. So this is the most important one, in my opinion. Then we talked about trans-chest wall pressure briefly, which is the pressure across the chest wall, the distending pressure of the chest wall, which we will not talk about today. And then finally, we talked about this transpulmonary pressure, which is the pressure difference between the airway pressure and the pleural pressure. And this is clinically relevant because, like I mentioned, transalveolar pressure is where the money is. This is what we want to know, but it's impossible to put a catheter in an alveolus. So the way we measure or sort of, estimate transalveolar pressure is in zero flow conditions, because like I said, when you have zero flow, trans-airway pressure is 0. So this pressure drop right here is 0. So in zero flow conditions, transpulmonary pressure equals transalveolar pressure, or it reflects transalveolar pressure. This is how we can clinically use transpulmonary pressure in practice, and we need an esophageal balloon to estimate the pleural pressure for this to work. And we talked about how clinically we can use this. Specifically, we can either do and inspiratory transpulmonary pressure, which would be the difference between plateau minus pleural pressure, or we can check and expiratory transpulmonary pressure, which would be the difference between PEEP and pleural pressure. So this is what we talked about this morning, and I thought I should review it before moving forward. So any questions so far about this? All right. So the first clinical application of this is assessing the degree of inspiratory lung stress. So we often use plateau pressures for this, right? So we talk about, hey, we got to keep the plateau less than 30. So in our mind, when we're trying to say that, we've got to lower the plateau, we are thinking about lung stress, right? We're thinking about how much stress the alveolar walls are seeing when we are inflating the lung during end inspiration. That's what we are kind of intuitively trying to minimize. So but we already mentioned that plateau pressure is, in our terminology, it's an alveolar pressure. It's not transalveolar pressure. This is, again, where the money is. This is what actually determines wall stress of an elastic chamber. So what we really want to know is transalveolar pressure. And so how can we do that? The missing piece is the pleural pressure. That's what we need to know. So let's take an example. All right, so there are 2 patients here. They both have the same plateau pressure. So you have patient A, who's a very lean patient, doesn't have any extra adipose tissue. And you say both of these patients have the same lung disease, ARDS or whatever, but they're very different habitus. The patient B has a BMI of 65, they're morbidly obese. So say they're ventilated with the same tidal volumes, and their plateau pressure is the same, it's 40. I'm not going to go into the specifics of what the other settings are. I don't know what their PEEP is or whatever. All of the information that I have at this point is a singular reading of plateau pressure that's 40 in both these patients. Now the question is, if we only focus on plateau pressure, that should mean that both these patients are experiencing the same amount of and inspiratory lung stress. Is that the case? Any thoughts on this before I tell you the answer?
It shouldn't be, because their driving pressures would be different, right?
Right, driving pressure we'll talk about. That's a slightly different definition, which is, it's a clinical term, which is your difference between plateau and PEEP. So that would be helpful. But the precise term would be what we really want to know is, so based on the 8 pressures we discussed today, what what pressure can we use to actually make that distinction?
So you want to know the transmural pressure. Therefore, you want to get your pleural pressure to be able to identify that.
Right, exactly. So you want to know your pleural pressure. So, so let's just, okay. So we put an esophageal balloon in both these patients, right? And we do an respiratory hold and we check the reading. The first patient, the pleural pressure during end inspiration is 5. So Patrick, you said you wanted the pleural pressure. So how are you going to use this now? You're going to subtract this from 40, right? So that's so your plateau minus your pleural pressure, that would give you your end inspiratory transpulmonary pressure. That's the key word here, end inspiratory transpulmonary pressure. In clinical words would be the best estimate for end inspiratory lung stress. So in this case, it's 40 minus 5 is 35, which is quite high. However, in the second case, because the patient has so much extra tissue on the chest wall, you can just essentially think about this patient has a sandbag sitting on his chest wall that's adding so much pressure from the outside, pushing in, that drives up the pleural pressure to 25. So in this patient, even though the pressure we're measuring on the ventilator at end inspiration is 40, but when you do the math and you take the pleural pressure into consideration, the end inspiratory transpulmonary pressure would be 40 minus 25, which is 15, which is totally different from the first patient. For the first patient, the end inspiratory transpulmonary pressure is 35. Second patient is 15. Even though the plateau pressure is the same, the end inspiratory transpulmonary pressure is the one that actually determines lung stress. It's drastically different between the two. So technically, like I said, I mean, transpulmonary pressure is not transmural pressure, Patrick, right? So it's technically airway pressure minus pleural pressure. But like I mentioned, here we are measuring pressures in zero flow conditions. So in this case, the transpulmonary pressure is a reflection of transalveolar pressure, which is your actual transmural pressure of the alveoli. So drastically different. Things are much safer in patient B than in patient A. So to put this in words, so if the end inspiratory pleural pressure is very high, like in obesity, your plateau pressure would overestimate lung stress. And this is actually being studied. And like we kind of in our head, the plateau pressure reading of 30 kind of sends red signals. For people who study transpulmonary pressure, they've kind of researched and a value of less than 20 is optimal. So in this patient B is actually less than 20, so he's fine. Patient A is in trouble, it's 35. And this is much more precise. Okay. Second application is finding optimal PEEP. So we're switching from inspiration now to expiration. So how would this work? So again, same concept. So PEEP also reflects alveolar pressure. So by itself is not a good metric of lung stress. So we do usually in most of the situations we use PEEP tables, right? So the PEEP tables do not give any regard to the heterogeneity of pleural pressure in our patients, and there can be quite a significant degree of heterogeneity. That's the number one kind of criticism of empirical PEEP tables. So what you can do to make it more precise is, we talked about end inspiratory transpulmonary pressure. You can also do end expiratory transpulmonary pressure. You can, again, instead of just using PEEP as a marker of lung stress during expiration, you can subtract PEEP with pleural pressure and use this number to better individualize PEEP. So remember I said for end inspiration, the magic number is 20. For setting PEEP, the way to do this is you set PEEP so that the transpulmonary pressure at end expiration is a little bit above 0, say 0 to 5. So if your pleural pressure at expiration is 15, you set your PEEP so that it's slightly above 15, like around 20 or so. This is how they do it in the trials. So again, similar, just to give you an example, this is a patient A, the lean patient, has ARDS, is on 100% FiO2, and we set the PEEP to 24 using the PEEP table. But you check the end expiratory pleural pressure, it's 4. So the lung stress in this patient would be high because if you do the math, the delta is 20. So you see this in this patient during expiration, the lung is so overinflated. Compared this to an obese patient, BMI of 50, pancreatitis, obese patient, so also has ARDS, and we use the same PEEP table in this patient, right? So we set a PEEP of 24. But in this patient, because of the extra mass, it drives up the pressure around the lung, the pleural pressure, to 24. So the delta here is 0. So you see the drastically different lung stress these two patients are seeing with the same PEEP setting based on how different their pleural pressures are. So again, just as in inspiration, we do an inspiratory transpulmonary pressure, and an expiration, you can look at an expiratory transpulmonary pressure to actually determine more precisely the amount of stress the lungs are seeing.
Mark,
And the second case, yeah, go ahead.
Just to clarify, just with the transmural versus transpulmonary, like, so my understanding was that at the end inspiratory holes, your intramural pressure should be your plateau pressure, and your extramural pressure would be your pleural, which would be dictated by your esophageal balloon. So would your transmural pressure be the same as the transpulmonary pressure in that circumstance?
Yes, that's exactly what I said.
Yeah.
So
oh, sorry.
Yep,
Sorry.
you're right. You're right. So I just wanted to clarify that you're right. So it's only valid in conditions of zero flow.
Yeah.
It's my only point. If there is positive flow, then the pressure at the airway opening would not be equal to the pressure in the alveolus. But for plateau pressure, we have to make the airflow zero. So in that condition, transpulmonary pressure is indeed a reflection of transmural pressure, which, specifically in this case, a transalveolar pressure. So you're right.
Okay, thanks.
Yeah. So again, just to put it in words, although the PEEP is same in these two patients, but an expiratory transpulmonary pressure is drastically different, and you can think of this as this can be thought of as the PEEP that the lung actually sees. So kind of TLDR of this is it's not just your PEEP and the plateau, it's also the pleural pressure that surrounds the lung that determines lung stress. So you have to subtract that from your PEEP and your plateau when you're trying to determine how much stress the alveoli are seeing. And this is the third one, slightly different from the first two, but it's important nonetheless, is to make this distinction between negative pressure ventilation and positive pressure ventilation. So this is a different module and a different lecture altogether, but just to kind of briefly mention, we often think about positive pressure ventilation as inherently evil and it can cause lung injury, whereas with negative pressure, with spontaneous breathing, you can do whatever you want, whatever tidal volume is not going to cause lung injury. I just want to challenge that kind of, that bias we have in our mind often between these two, using respiratory mechanics. Like I mentioned, remember the balloon video that we saw? I mentioned then that, it doesn't matter how you create a transmural pressure. The only thing that matters is the value of the transmural pressure, which would then decide the volume of the balloon, which would then decide the stress on the wall of the balloon. It doesn't matter how you create that transmural pressure. So same thing for the alveolus. For alveolar filling, all that matters is the transalveolar pressure reading. It does not matter whether that particular pressure was generated via negative pressure ventilation, positive pressure ventilation, or a combination of the two. Just to put this in numbers, and these are a little bit sort of oversimplified, but it'll make the case nonetheless. So you can take this first patient, which is on a pressure control, and he's totally paralyzed, and getting say a delta pressure of 20, and the PEEP is 0. So at an inspiration, the pressure at the airway pressure is 20, which would mean that at an inspiration there's no airflow, so all that is being delivered to the alveoli. So your alveolar pressure is 20, but at the same time your pleural pressure at an inspiration is 10. So in this case, your inspiratory transpulmonary pressure is 10. And compare this to another patient, actually the same patient, say, who is breathing spontaneously, and during spontaneous breathing generates a pleural pressure of -10 right here. And this may not be intuitive initially, but at an inspiration, when we breathe spontaneously, our alveoli are in direct connection to our mouth opening and hence the atmosphere. So the airway opening pressure as well as the alveolar pressure at an inspiration in spontaneous breathing would be 0. So anyways, the point is, in this case, with negative pressure ventilation, the inspiratory transpulmonary pressure is the same, right? So these two conditions, same patient. First scenario is totally passive, positive pressure ventilation. Second scenario, totally active, spontaneous breathing, generates the same transpulmonary pressure. In these two scenarios, the degree of lung stress, it would be absolutely identical. It does not matter how you create that volume in the alveolus. The only thing that matters is how full the alveolus is, and then that would decide how much the wall of the alveolus is stretching.
Sorry, Matt, just to clarify from my understanding, with the passive end inspiratory pause in the first example there, that positive pleural pressure, is that just as a result of overall positive ventilation leading to increased intrathoracic pressure? Is that why that's 10 as opposed to 0 or -10, whatever it may be?
Yes, absolutely. And this would be a separate lecture on chest wall mechanics, but you're absolutely right. So in this case, you are passively expanding the chest wall by pumping in air from above, right? So that would increase your pleural pressure, which would be a function of your chest wall stiffness. So essentially, that's without any muscle activity. That's totally passive chest flow. In the second case, the way you generate ventilation is actually by using your inspiratory muscles, and the first thing that'll do is create a negative pleural pressure, right? That's how we all breathe. So the intricacies of these two is difficult to kind of talk about in one slide, but just know that during passive ventilation, your pleural pressure is going to go up, but with spontaneous breathing, negative pressure ventilation, your pleural pressure is going to be negative, and that itself would drive ventilation. And then I've said this several times, but just to kind of really hit home, it doesn't matter how a particular transmitter pressure is generated. It can be either by increasing the intramural pressure or pressure within the chamber, or it can be by reducing the pressure outside the chamber, like in negative pressure ventilation. A particular transmitter pressure will result in the same degree of inflation and the same wall stress in a particular object. And this is recap. So that's all we have. We have a few take-home points. So ventilators measure pressure at the airway opening. So that would be the pressure at the airway opening, PAO, or airway pressure, PAW. Plateau and PEEP reflect alveolar pressures. And the pleural pressure has direct hemodynamic consequences. That's a separate discussion. The trans-airway pressure exists because of resistive pressure drop across the airways. And if there's zero flow, there would be no trans-airway pressure. Trans-alveolar pressure determines alveolar inflation and alveolar stress. So since plateau and PEEP reflect alveolar pressure, they don't actually directly determine lung stress. So in the absence of airflow, the trans-airway pressure is zero, and therefore the airway pressure is a reflection of alveolar pressure. For example, that's how we measure plateau. Also, the transpulmonary pressure then equals or becomes a reflection of transalveolar pressure, and this is why clinically we can use transpulmonary pressure to actually determine lung stress in zero flow conditions. And this is how we do it. We can check end inspiratory or end expiratory transpulmonary pressures, like I described in the examples before. And these would then reflect transalveolar pressure and are hence true markers of lung stress. From the mechanics standpoint, the alveolus does not care whether a given transalveolar pressure is generated by a negative, positive, or a combination of two. And these are the poll questions. So the transpulmonary pressure is defined as airway pressure minus pleural pressure. We talked about this. This was the case in the first slide. So what I was trying to make a case was this is a morbidly obese patient, has a PEEP of 20, has ARDS, his P2F is 50. You put an esophageal balloon in this patient, and your end expiratory esophageal pressure is 24. So what do you do now? So when you do the math, you can see that at end expiration, the transpulmonary pressure is 20 minus 24, so it's a negative. So that is not what you want. So you can use this information and say that, hey, my transpulmonary pressure at expiration is negative. I don't want that negative. It has to be at least zero. So this is one way to set optimal PEEP. It's not perfect, but this is a physiology conversation, not clinical. But technically, you can use this information to then say, hey, I probably have to go up on my PEEP. So this would be the right answer in this case. All right, I think that's all I have. Questions?
I have a couple of comments. Just some clarifications that I think that are important. If you can go back a couple of slides. There, no, where you were, one ahead. One more, and yeah, fill it up. First of all, great job. It's a very you had to read a lot to get such a level of understanding on how this is about transpulmonary pressure, and I really appreciate the presentation. These are just details, but I think that they are important for us to highlight. I think that the first one is related to your second statement that says plateau pressure and PEEP reflect alveolar pressure. I would say PEEP only reflect alveolar pressure if you do an end expiratory pause. As you know, there may still be flow generating from auto PEEP units that have less different time constants. So I don't want the team to think that the PEEP is equal to what the alveolar pressure is seeing during end expiration. I think that you would agree with that.
100%. Yep, has to be zero flow.
Yeah. So the same way that you do a plateau pressure in which you want zero flow, you have to do an end expiratory pause and that will reflect the alveolar pressure. And that's why we do that when we're measuring the driving pressure for these patients. The second part that I thought that it was important to highlight is where you, in the next slide, when you talk about that there is no difference between how you inflate the alveoli, if it's negative pressure or positive pressure. And I will just highlight that I wish that that's the most simple single compartment view. And under those circumstances, it is true that it doesn't really matter what it is. But in a complex system in which you have different geometry, walls, the inflation of the alveoli is not uniform. And the inflation of the lung is not uniform for a given transpulmonary pressure, such that in patients that have injury, the amount of pressure and how it distributes through the lung may cause different regional transpulmonary pressures for the same measurement of pleural pressure that you're doing for patients on positive pressure ventilation or negative pressure ventilation or self breathing. So I think that we are not there yet, that the same tidal volume that you may deliver with the same pleural pressure, the distribution of that volume may have differences in how it affects the regional stress and strain of certain units. And I think that you would agree with that too, but I want to hear your comments.
Yes, absolutely. So this is great because this is something I think about a lot. And so I chose my words like very carefully, or I tried to at least. And this is a thought experiment. And this is when we're talking about theoretically in a single alveolus. So in a single alveolus, this is just physics and mathematics, and I don't think there'll be any argument. What you're saying is 100% valid. Is the pattern of inflation is totally different between a positive and a negative pressure ventilation, and the distribution of ventilation would be different between a positive pressure and a negative pressure ventilation. There may be certain factors that would make it so that actually vigorous spontaneous breathing might actually be more harmful than positive pressure breathing, and vice versa. Factors including Pendeluft and so forth, which would take a long discussion. But actually, if someone's interested, I've written a blog post on this, and it's probably the longest post I've done, and I'll be happy to share it with you later. Detailing all these different minor factors. So overall, absolutely, when you take the whole lung as a whole, then the distribution part becomes very important, and there are subtle differences. But I still believe that the reason I brought this up was we have this inherent thinking that you can have a spontaneously breathing patient and they can do whatever and it's going to be okay because they're not on a ventilator. So this whole idea of patient self-inflicted lung injury, there's some merit to it. Even though we can talk about the nuances.
Absolutely. I'm not refuting. I think that that's a very valid point. As you point out, this is just a simple view so that you understand the concepts, but it goes deeper and deeper than that, and actually pretty nuanced discussion. That I wish it was as simple. But I really applaud the effort. Thank you, Tim.
Yeah, we should probably do a separate talk on that someday.
Yeah.
Any other questions?
Just one more question. In regards to the esophageal balloon, can you use that end inspiration and end expiration?
Yep.
Yeah, that's how we do it.
There's a nuance there that we will talk a little bit more. Is that based on studies done putting pleural pressure measurements, the esophageal pressure in a patient that has ARDS, which is usually the patient that you put it on, manifests the pressure at the dependent areas of the lung, not at the apical areas of the lung. So it seems that it's a good measurement to do a simple math with the end expiratory pressure. But for the end inspiratory pressure, when you're trying to calculate how much strain or stress is occurring at the end of the breath, i.e. during the plateau pressure, you have to use something different, which is a ratio of elastance, which is a calculation. And so there's a fudge factor there, but it seems to be the one that correlates the best. So the simple answer, yes, you use the esophageal pressure for both, but there's a ratio that you may apply for the end inspiratory pressure.